Hello, and welcome to Movie Phone. No, guys, this isn't Movie Phone. This is Hemodynamics. This is one of the first in our series of our CEN review topics. Hemodynamics isn't covered extensively in the CEN, but it is the basis for a lot of the other topics. Having a good understanding of hemodynamics helps us better to understand cardiovascular emergencies, multi-system failures, traumas, sepsis, shock, those type of things. Having some sort of understanding of that will kind of help carry some of these other themes along. So just a really quick review over the gross anatomy and the blood flow through your heart. Essentially, all your blood returns via the superior vena cava and the inferior vena cava into your right atrium. From the right atrium goes to your right ventricle. From right ventricle into your pulmonary arteries, goes out to the lungs, gets its oxygenation on, returns back via the pulmonary veins into the left atrium, into the left ventricle, to the aorta, and then out back into the body. So talking about this blood flow, we're really looking at the cardiac performance, which is the cardiac output. This is the amount of blood that's ejected by the heart in 1 minute. It's about 4 to 8 liters, depending on the size of the person and, of course, their cardiac function. If we look at cardiac output and we further break it down, what cardiac output is really the stroke volume and the heart rate, which is the beats per minute. And then stroke volume is further broken down into 3 components, which we're going to get into. So we're first going to focus on heart rate. Heart rate is the first component of that cardiac output, and it really is the first mechanism that changes to help maintain that output. Maintain that output that is supplying the perfusion to all your body tissues. There's a few things that might change your heart rate and cause that compensation. It's really regulated by your autonomic nervous system. Sympathetic stimulation increases your heart rate, parasympathetic decreases your heart rate. It responds to baroreceptors, which are in your carotid and your artery, which are literally sense the drops in your blood pressure, and that will send signals to your brain to either speed up your heart rate or lower your heart rate, again, to maintain that output. You have your chemoreceptors, which are really your body's own epinephrine, norepinephrine, dopamine that's released through the adrenal glands, and your metabolic rate that is regulated by your endocrine system. So looking at changes in heart rate, essentially when we first see a drop in cardiac output, your body is told to increase the heart rate. And increasing the heart rate does increase the cardiac output. Obviously, if I'm beating faster, I'm going to push out more fluid, so that is going to increase my output. But it has its limitations. And really it is, if I'm beating so quickly, I'm not going to get that stretch where the ventricles are going to have the time to fill up. So if they're not filling up, that is your stroke volume, and I'm not going to have enough volume to push out. So eventually that compensation decompensates, and it's only going to sustain me for a certain amount of time before I'm going to need some other intervention. And obviously, if my heart is tick-tacking away, it's beating fast in order to meet this increase for cardiac output, to produce that increase in cardiac output, it's going to need more oxygen and more energy to sustain that. Essentially, your heart cells are working harder, so they are going to increase what they need. If those things are not ready available, then you're going to have ischemia to those heart cells. You're going to have a breakdown of those heart cells. Decrease in heart rate obviously will decrease cardiac output. It decreases the demand. It does allow for an extended diastolic filling time, and it does increase coronary perfusion. Coronary perfusion happens in our diastolic stage. It's when our heart is relaxed after the body. Essentially, in the systolic phase is really where it pushes out the blood to perfuse everything else. It feeds itself to say when it's relaxing, and that's when the perfusion happens in the heart. Obviously, this is a good thing when your heart is very efficient and it can have a lower heart rate, but too low is I'm not pushing it out enough, and then I'm going to have alterations in cardiac output because it's just I'm not pushing out enough fast enough. So they have their benefits, have their issues. Again, nothing really stays in one category. This is all regulated and changing based on the signals that your body gets throughout those different avenues. Stroke volume, as I said, that's the filling of each ventricle in that beat. And if it's too fast for that to fill, you're going to have less stroke volume. If it's a little bit slower, you're going to have better stroke volume. And when we look at stroke volume, we're looking at 3 determinants that make up stroke volume. And that is your preload, your afterload, and your contractility. So contractility is the actual muscle strength of your heart. It's the ability of that ventricle to push out that fluid. It's that strength. It's really influenced by preload, which we'll talk about in a minute. And there's no real good way to measure contractility. The most we'll see is if we do like an echo with an ejection fraction, and that gives us a little idea to the contractility. But again, it is looking at the outflow of how much stroke volume your heart can push out. But that gives us some idea. But otherwise, on a minute-to-minute basis, contractility is very difficult to measure. We usually know it's a contractility problem. If it's not a preload problem and it's not an afterload problem, well, that leaves me with one thing, right? So I have to address the actual strength of the muscle. There are certain things that will decrease contractility. Those are your electrolyte imbalances, especially when it comes to sodium, potassium, calcium. Those are all the channels that work in our heart which help us with the contractility. Myocardial damage, so if the actual cells have been through some sort of ischemia, they've had some sort of infarction, that they have completely damaged and remodeled, obviously they're not going to respond to the electrical impulses of the heart. So they're not going to have that same contractility. And this is what really is what you see in those CHFers, that they have these like floppy, weak hearts just over the extended time that they've had so much damage to the individual myocardial cells. And then hypoxia. Obviously, the cells want oxygen to work hard. They need it to work to beat fast, and they need it to work to have that extra strength in their squeeze. If oxygen isn't readily available, the heart is going to say, hey, like, why am I working so hard? So it is going to decrease that strength, that contractility, if you do have hypoxia present. And then there's the increase in contractility. These are your inotropes. These can either be naturally produced dopamine, epinephrine, and norepinephrine from our own bodies, or the chemicals that we see that we actually give our patients, the synthetic versions of these drugs that help them with their blood pressure regulation. Looking into preload, this is the volume that is in the ventricle at the end of the diastolic phase. So this is the last fill right before it ejects out of the ventricle with the systolic end of your cardiac cycle. Frank Starling's law, we're going to get into that in a minute. CVP and PAWP are the hemodynamic measures that you might hear about. These are invasive measurements. Really, the CEN doesn't focus too much on CVP or PAWP, but just for general knowledge, CVP is your central venous pressure. It is looking at the volume coming from your central veins, which would be your vena cava, superior and inferior. And it's really looking at the preload of your right ventricle, because that's what's going in. Where did the blood come from? It's coming from the veins into the right ventricle. And your PAWP, or sometimes it's referred to PAOP, is your pulmonary artery wedge pressure or pulmonary artery occlusion pressure. And that's essentially it's an indirect measurement. It's looking at the volume that's coming back from the lungs. Obviously, I don't have a catheter that's designed to look at the volume at the capillary level in the lungs. So the best place that I could do it is right before the lungs is the pulmonary artery. That's the volume that's about to go into the lungs and get oxygenated. So what they do is they have special catheters, a Swan-Ganz catheter that actually has a little balloon, and you inflate that balloon and you'll see it will give you that wedge pressure. It's wedged in the pulmonary artery, or that occlusion pressure. It's occluded the pulmonary artery, and it gives you an indirect measure of the left ventricle. So CVP generally is 2 to 6, and PAWP is usually 8 to 12. And then going back to our preload and contractility is our Frank-Starling law. This is like the rubber band law. I'm going to have more filling if I have more stretch in my vessels. Just like if I pull back on a rubber band and I let it go, the further I pull it back, the more it's going to snap back. Or if I have a balloon filled with water and I stretch that balloon out till it's about to burst and then I let it out, it's going to have more force. So more preload actually increases that contraction, that stretch. And this is really why runners, people that are very athletic, have such low resting heart rates. It's because their body is so efficient that their ventricles fill and stretch so well that in one contractility, one contraction of their heart, that strength that they have pushes all this blood, and it's enough to sustain their output. So they don't have to have that compensation of having their heart work really hard to get that volume out. So preload problems are volume problems. So you have to think, if I am overloaded, if I have too much volume, if my CVP or PAWP measures are elevated, I have to think of ways to reduce it. So that would be diuretics or venodilators like nitroglycerin. If I want to have volume, if my volume is low, if those measures are low, less than 2 or less than 8, I need to find ways to increase volume. And the way I increase volume is by giving volume. Either I give you fluids, normal saline, lactated ringers, or I give you some sort of products, blood products, albumin, which changes the, essentially it pulls in the fluids into the vessel from the interstitial tissues into the intravascular space. So it helps to draw that fluid in. That's how I would correct those issues. So looking into afterload, that's our last determinant of our stroke volume. And afterload really is the force that my ventricle has to overcome in order to push out that blood. Essentially how it's going to push that blood out into the body, into the vessels. How vasoconstricted or how vasodilated those vessels are is going to make that job easier or harder. If I have these giant fire hose for vessels, when I go to squeeze, it's not going to be as hard to get that blood out into that fire hose. Essentially, my afterload would be low. If I have these very, very vasoconstricted little micro vessels, my heart is going to have to squeeze a lot. It's going to have that force to overcome to get that volume into those vessels. We measure afterload by PVR and SVR, your pulmonary vascular resistance, which is the force of the right ventricle that has to overcome to get the blood flow into the vessels in the lungs, the pulmonary vascular resistance. And in the left ventricle, it's your systemic vascular resistance, which is the force that your ventricle has to overcome to get the blood from the left ventricle into the systemic vessels in your body. So it is your systemic vascular resistance. Afterload problems are vessel-tone problems. So if I am very vasoconstricted and I need to decrease that, I'm going to give vasodilators like nitroglycerin or nipride. If I am very, very vasodilated and I have essentially no afterload, I need to increase it. I need to give vasoconstrictors. And this is what we see when we treat different types of shock and especially sepsis. We essentially are trying to increase that afterload, that pressure, in helping it increase our cardiac output by vasoconstricting. Now, one important rule to understand about hemodynamics is I can constrict vessels, and that will help me to some degree. But if I don't really have anything in those vessels when I constrict them, if they're like empty fire hoses or uh, empty vessels, I'm not really getting any more perfusion out of them. I should always address preload problems first. Preload kind of gives you a hint before I address afterload problems, because I need to make sure that I have something in that vessel. Like the cup isn't empty. I need to make sure there's some sort of volume. And then once the volume is in there, then I can rein it in and squeeze it in and get it to the right places and essentially improve cardiac output and perfusion. There's a couple different vasoactive drips that we use in the emergency department. Some of these we do see more extensively in the ICU, but just a quick review, different drugs are used for different effects. A big fan favorite is norepinephrine because it tends to have a really good blood pressure effect with not having too much of effect on the heart rate. So it won't make you terribly tachycardic. The one bad thing is that it really does work on these alpha receptors, which are in the vessel. So it really, really will vasoconstrict. It really will work in the actual vessels in your body. And when you have these tiny vessels, especially in your hands, in your distally, in your toes, in your feet, when I really, really clamp down in those areas and I start to shunt the blood to my core, which is something that your body naturally does in shock, and then I come in with this vasoactive drip that's really going to clamp down these vessels further, it can actually clamp down the vessels so much that it causes this peripheral ischemia. Like my fingers and my toes are not going to get perfusion because essentially I blocked the passage. They're so constricted that it's not enough blood now can go through those vessels to perfuse those areas. But it still is probably the first line treatment for a lot of our shocks. Epinephrine, we usually piggyback it. Once we see that norepinephrine might not be working, we might go the route of epinephrine or vasopressin. Epinephrine, we try to avoid it because it really is taxing on the heart. It really increases heart rate. It really increases your blood pressure. Epinephrine is a better choice for those patients that are either both a respiratory and a vascular issue. So really our patients in like an anaphylactic shock that do need all that beta stimulation can benefit from an epinephrine versus there's other alternatives than going straight to an epidrip, which might be a little bit too much on the heart. Phenylephrine used to be the fan favorite, and I'm still kind of a fan. I don't know why we don't use it as much as we do. It's usually, again, something that's used a lot in anesthesia. When a person has like an acute blood loss in surgery, they give a little squirt of phenylephrine, and then like magic, you're beautiful and your blood pressure is perfect again. It only works on the alpha receptors, which are in your vessels. Does have some of those same effects as norepinephrine because again, it's working on the alpha receptors. Is a little bit shorter acting, but still a relatively good drug. It's just something we don't see used too often outside of the surgical suite and in some ICUs. Vasopressin used to be the standard of care. Now it's usually what we tack on when we see that our norepinephrine is not working. We need more vasoconstriction. We need more help. It does help with the BP, can cause a lot of myocardial, coronary vasoconstriction, which will cause issues with how well the heart is perfusing. So we usually use it once my BP is still really low. And I have other vasopressors working, but I just need a little bit more support. This is for like the dead and dying patients. So then we're going to throw vasopressin on there. And then dopamine is again an old fan favorite. Dopamine does have the benefits that in lower dosages it helps increase renal perfusion, so that's why some doctors still like to go that route. Um, if we have enough going in that, obviously the kidneys are the first to go. If we have something that's going to help them perfuse in these low cardiac output type scenarios, we do like to go that route. It does cause a lot of heart stimulation, does make people tachycardic. So sometimes that's why we don't use it. But dopamine, for those patients that are bradycardic and their cardiac output is poor related to the bradycardia, we do see dopamine as kind of like the drug of choice. Blood pressure is your cardiac output times your systemic vascular resistance. Though we really don't look too much at blood pressure, we're looking more at our mean arterial pressure. It's the pressure in the arteries. It's the indicator of our tissue and organ perfusion. There's a lovely formula. You guys can knock yourself out plugging in numbers, or you could just look at your monitor. It's the little number in the parentheses next to your blood pressure reading. And essentially, you're going to see in different literature, some literature will tell you above 60, some people will even say above 70. Kind of standard around the board is above 65. That is the minimum for all the tissues in your body to perfuse. Just like I was saying, the kidneys are kind of like the first to go. That's really end stage. Renal perfusion can happen with a MAP of at least 60 to 65. So when we titrate our drugs, tongue-tied, titrate our drugs, we usually titrate it to a mean arterial pressure of above 60, above 65, because at least we know that our kidneys are perfusing, we're going to make urine, and our patients will not end up on dialysis a few weeks down the line. Tissue perfusion, if I have low cardiac output and I have poor vessel tone, eventually my oxygenated blood is not going to reach my tissues, and I'm going to start to have poor tissue perfusion and poor oxygenation of those tissues. And for the most part, my body can function a little bit with a little less perfusion, a little less oxygenation. It compensates, it tries to do the job. And what it will do is it'll switch from an aerobic metabolism to an anaerobic metabolism. That just means essentially a metabolism without oxygen. And when it switches over to this anaerobic metabolism, lactic acid is the byproduct. That's why we run lactic acids on patients, because if my lactic acid is high, it means my body is in an anaerobic metabolism. That means my body is not getting adequate tissue perfusion and probably has some sort of poor oxygenation of those tissues. So that's why lactic acid is there. That is why the indicator, the higher that lactic acid is, the worse the situation is. And that's why we kind of gauge our treatment by how bad the lactic acid is, the level. That lactic acid is an acid, so eventually it will cause an overall metabolic acidosis of the body. And your body can sustain itself with a little perfusion and a little oxygen, but over an extended amount of time, in that acidotic state, your body says, I'm not here for this, I'm done, and the tissues start to die, and you essentially go into organ failure. This is also a reason why we give bicarb in those very sick patients. It is a mechanism to help us reverse that metabolic acidosis, to help the body tissues sustain itself while we correct tissue perfusion issues and oxygenation issues. Also, a lot of drugs that we do give patients don't really work well in the cellular state in a acidotic environment. If you're very, very acidotic, your body doesn't even respond to drugs. So we need to have some sort of correction of that acidosis if we're really going to help the patients, and then address the underlying issues that are sending this patient in this cycle, which leads them all the way to tissue death and organ failure. So thanks for tuning in to our really quick overview over hemodynamics. I hope it helps us understand some of the other concepts that we're going to dive into later. Other considerations to maybe think about when studying is also looking about those physical assessment findings. What does a patient with fluid overload look like? What does a patient who looks like they have poor perfusion look like? What does a person look like that has low volume? Just little things to consider, and those are some questions that you also might see come across the test. But I hope this is a good jump point, and we can get into a few more topics down the line. Thanks for listening.